In this film, a vacuum-assisted delivery will be demonstrated. This type of delivery is also known as a ventouse delivery. A vacuum-assisted delivery may be performed for maternal or fetal indications. During a vacuum-assisted delivery, the following implements may be used. For the internal vaginal examination, sterile gloves and lubricant are used. For the catheterization, sterile gloves, cotton swabs, disinfectant and a single-use catheter are used. For the episiotomy, a syringe filled with local anesthetic and infiltration needle and either a Brown or Waldman episiotomy scissors are used. Gauze swabs may be useful in managing blood loss after performing the episiotomy. For the extraction of the fetus, a vacuum delivery device is used. And finally, for the clamping and cutting of the umbilical cord, 2 clamp forceps, a pair of scissors, and 1 plastic umbilical cord clamp are used. The clamping and cutting of the umbilical cord are not shown in this film, however. For a more detailed elaboration of this, refer to the course Management of the Third Stage of Labour. The mother is placed in the lithotomy position with her legs positioned in stirrups and her buttocks at the edge of the bed. The urethral orifice is disinfected by using the gauze swabs and disinfectant. Care is taken to spread the labia using the non-dominant hand. The labia majora are then disinfected, and subsequently the labia minora and the urethral orifice are disinfected. Care is also taken to ensure sterile technique is used. 1 gauze swab at a time is used, using 1 continuous motion, going from the urethral orifice towards the anus. It is then discarded. The urinary bladder is emptied using a single-use catheter. The pelvic diaphragm is anaesthetized with a local anesthetic in case the episiotomy needs to be performed. If epidural anesthesia is given, this is not necessary. Take note how the index and middle finger of the healthcare professional are placed into the vagina to keep the needle away from the fetal head. Also take note how the plunger is retracted before the anesthetic is injected to check for blood, which indicates that the needle is in a blood vessel. To prevent intravenous injection, the needle should be retracted and the maneuver repeated. The index and middle finger of the healthcare professional are lubricated, and the position and engagement of the fetal head is assessed by performing an internal examination. Based on these findings, the type of vacuum and the preferred type of cup can be determined. If the position of the head is unclear during an internal examination, an intrapartum ultrasound may be performed to confirm the fetal position. Take note that a fully dilated cervix and ruptured membranes are essential conditions that must be fulfilled before performing a vacuum-assisted delivery. Vacuum-assisted deliveries may be categorized into 4 groups. The categorization is based on the level of descent of the fetal head, as measured using the Hodge planes or stations. The 4 groups are the high vacuum, the mid vacuum, the low vacuum, and the outlet vacuum. The high vacuum is where the skull of the fetus has not engaged and is above Hodge 3, or 0 station. The mid vacuum is when the fetal skull is at Hodge 3, or 0 station. A low vacuum is when the fetal skull has passed Hodge 3 and is at the +2 station, but not yet at the pelvic floor. The outlet vacuum, when the skull has reached the pelvic floor, known as Hodge 4 or +5 station. In an outlet vacuum, the fetal scalp is visible without spreading the labia. The sagittal suture is positioned less than 45 degrees from the midline in either an occipito-posterior or an occipito-anterior position. Take note of the vacuum delivery device with the rigid plastic cup that is placed onto the fetal skull, the foam filter inside the cup that prevents blood and fluid from being sucked into the device, the flexible stem between the palm pump and the cup that contains an air tube to create the vacuum, the palm pump that is used to create a vacuum as well as serving as a handle to pull on during a contraction, and the pressure gauge that indicates the amount of pressure that has been created with the palm pump. An internal examination is performed to determine the flexion point on the fetal skull. The flexion point is located on the sagittal suture and lies 3 cm anterior to the posterior fontanelle. Take note of the location of the posterior fontanelle, the sagittal suture, the anterior fontanelle, and the flexion point, 3 cm anterior to the posterior fontanelle. Take note also that the centre of the cup overlies the flexion point. And the brim of the cup almost reaches the posterior fontanelle. The cup is lubricated, inserted into the vagina sideways, while the non-dominant hand spreads the labia and pulls the perineum dorsally to create more space. And the cup is then placed onto the flexion point of the fetal skull. Care should be taken to avoid placement directly over the fontanelle. Correct placement will facilitate flexion, descent, and rotation of the fetal head when traction is applied, and will minimize injury to both the fetus and soft tissue of the birth canal. Take care to ascertain no maternal tissue is trapped between the fetal skull and the cup. Once the cup is in the correct position, a vacuum is created by using the palm pump. The pressure is increased to approximately 600 mm of mercury or 0.8 bar to create an artificial caput succedaneum. Take note of the pressure gauge indicating the current pressure. Care should be taken not to exceed the indicated limits. Here, excessive pressure is indicated by the red zone. In general, 0.8 bar is enough to keep the cup attached to the head while still preventing injury to it. If the cup needs to be repositioned, the pressure gauge may be pressed to release the pressure. After creating the vacuum, the cup placement is checked once more. No maternal tissue should be felt between the cup and the fetal head. Once the vacuum has been created, the index and middle finger are placed on the fetal scalp, and the thumb of the non-dominant hand is placed on the back side of the cup to prevent cup detachment and monitor fetal descent. Traction is then applied with the dominant hand in the direction of the birth canal. It is advised to only apply traction during a contraction. Sometimes additional hand pumps may be necessary to maintain adequate pressure. Take note how the ridge on the cup was placed in line with the sagittal suture in order to monitor rotation of the fetal head. Care must be taken not to rock the vacuum delivery device sideways or to manually rotate the fetal head, since this may lead to injury of the fetal head and slipping of the cup. During the crowning of the head, an episiotomy may be performed, as is simulated here. Take note that to deliver the head it was first pulled caudally and is finally pulled in a caudoventral direction to follow the shape of the birth canal. After the delivery of the head, the vacuum is released by pressing the pressure gauge or vacuum release button, and the cup is removed. Take note once more how the pressure gauge is pressed and the cup is removed. Care must be taken not to perform more than 3 pulls or to exceed a time of 20 minutes for a vacuum delivery. A forceps delivery, caesarean section, or even a symphysiotomy should then be considered. If the healthcare professional deems the chance of success to be low, it is advised to perform the vacuum-assisted delivery in the operating room in order to allow for a quick conversion to a caesarean section if necessary. After the external rotation of the head, the fetus may be delivered according to the normal vaginal delivery.